Welcome to another episode of Grounded in Science, Centerstone Conversations. I'm Laurie Lebo, and today I'm talking with Dr. Heather Burrell Ward, Director of Neuromodulation Research and an assistant professor in the Department of Psychiatry and Behavioral Sciences at Vanderbilt University Medical Center in Nashville, Tennessee. At Vanderbilt, Dr. Ward is a physician scientist who treats patients and runs her own research lab testing transcranial magnetic stimulation as a novel treatment for psychiatric disorders. Recently, I had the privilege of touring Dr. Ward's TMS clinic and her research lab, and I'm delighted that she has agreed to talk with us today about her work in the area of transcranial magnetic stimulation. Dr. Ward, welcome.
Thank you. Thank you so much for having me. I'm excited to talk all about TMS and clinical work and research.
Great. That's exactly what we want here. Dr. Ward, on behalf of Centerstone's providers, our clients, advisors, members of our behavioral health community, what do we need to know about transcranial magnetic stimulation?
Yes, there's so much to learn. So TMS, or repetitive transcranial magnetic stimulation, is a form of non-invasive brain stimulation that's FDA approved for the treatment of depression, obsessive compulsive disorder, and for smoking cessation most recently. So TMS involves using a coil that's about the size of an old-fashioned telephone receiver, and we put that coil on the scalp and target a particular brain region or brain circuit. And we pulse an electrical current through copper wires in the coil, and that generates an electromagnetic field. And that electromagnetic field stimulates the neurons immediately beneath the coil. So we can stimulate neurons and increase their activity to treat various psychiatric disorders. So for depression, TMS has been FDA approved since 2008, and people come in every day for treatment for 6 weeks. And again, we're using TMS to increase activity in certain brain circuits that we know are involved in depression.
That is fascinating. That is just fascinating. Tell me, if someone is receiving TMS treatment, what does it look like when they come into the clinic?
That's a great question. So TMS is a completely outpatient procedure. So like I mentioned, for depression treatment with TMS involves anywhere from 4 to 6 weeks of daily treatment. So people come in Monday through Friday every day to receive treatment. Basically, they come in, they sit in a chair, we place the coil over a brain region called the left dorsolateral prefrontal cortex, again, in the frontal lobe. And they sit in a chair and get the stimulation for anywhere from 3 minutes up to 40 minutes. And then they go home. And you do that every day, Monday through Friday, for generally about 6 weeks. And in contrast to something like ECT, ECT involves anesthesia. TMS does not involve anything of the sort. We don't administer any medications. And so people can come in, get their treatment, and they can leave and go right to work, go about their day-to-day business.
Dr. Ward, you mentioned electroconvulsive therapy or ECT, and it sounds like they're awfully similar, the TMS and the ECT. Can you tell me a little bit more about what's the difference between the two treatments?
They're very different. So they're both forms of brain stimulation, but ECT involves the administration of a generalized seizure by applying an electrical current to the scalp, and that's done under anesthesia. And ECT is used for treatment of depression, psychosis, mania, catatonia, and autism. There are lots of different uses for ECT. However, people often complain of the side effects from ECT, especially memory impairment, like short-term memory loss. TMS is quite different. So again, it involves the use of a coil that generates an electromagnetic field. And it's that magnetic field that stimulates neurons to fire. And what's really important to know about TMS is that it stimulates a really tiny region. So think about a couple centimeters in diameter that it's stimulating. So in contrast to something like ECT, where you're getting stimulation of neurons across the entire brain, where we can't localize to just stimulate one particular region, TMS is the opposite. TMS is highly focal. We can target TMS to a particular brain region or brain circuit, really in the centimeters space scale. And so In addition, I mentioned TMS does not involve anesthesia. It's entirely outpatient. Someone comes in, they sit in a chair, they get the TMS, and they can leave, go right back to work, go right about their day. We don't administer any medications at all with TMS. Sometimes if someone has a headache after the fact, they could take Tylenol or ibuprofen. But really, it's just very, very different from ECT. ECT, a highly effective intervention. TMS also effective, but just sort of gentler is the way I think about it, and much more focal. And so both are used for the treatment of depression. ECT is often administered on an inpatient basis for really the most severe depression. TMS is on an outpatient basis, generally for people who are struggling with depression. Their medications haven't worked, psychotherapy hasn't worked, and they're just not doing well, and they need a more effective treatment, but they don't need to be, their depression is not so severe that they need to be hospitalized for it. So it's
Okay.
sort of in between these two, in between on one hand, like medications and psychotherapy, on the other end of the spectrum, something like ECT. TMS is sort of right in between.
Do you see in the future, do you see the need for both treatments to exist, or do you anticipate TMS replacing the ECT?
I think we need both of them.
Yeah.
TMS is effective, but there are definitely some people who don't respond to TMS and ultimately will need. And so I think, certainly for depression treatment, we need a lot of different options. And I think they're both really important options to have, especially when medications haven't worked. Medications and psychotherapy haven't worked. So I think they're both really important options to have at our disposal, and will continue to be in the future. I just think TMS will increasingly become more and more effective.
Mhm. More and more effective. And I'm wondering if there are clients who are currently potentially receiving ECT who might be able to benefit from the gentler approach of TMS.
It's possible. I think
I
especially if we think about clients who might be experiencing side effects from ECT and are starting to think that, gosh, the side effects are worse than the benefit. Or if someone's not getting benefit from ECT, TMS could certainly be something to consider. Again, ECT, highly effective, a great intervention to have, but I think we need both of those. Yeah.
So while they're receiving their treatment, whether it's, a couple of minutes, or I think you mentioned up to 40 minutes, what are they doing? Are they reading? Are they watching TV? Does it matter what they're thinking about? Does it?
Yeah, that's another great question. So most people just sit there. Some people will listen to music. You could read. You have to stay still because we want that coil to stay in place. But there's actually a lot of research going on to answer that exact question of, does it matter what someone is doing? And so interestingly, in the FDA cleared protocol for smoking cessation, we actually increase someone's craving for cigarettes right before applying the TMS. So there's some evidence actually that if you activate the brain circuitry that you're about to stimulate with TMS, that maybe it makes it more effective, but we don't completely know. So that's an open question for the field.
Dr. Ward, that's fascinating. I think there's so much still that we have to learn about TMS, and I'm hoping that you can share a little bit about some of your research interests too. As I was preparing for our interview, I was doing a little bit of research on my own and saw that there is some work being done in the area of opioid use disorders and opioid use treatments. Can you tell us a little bit about that and what you know about that area?
Yeah, so my lab very broadly investigates TMS as a novel intervention for psychiatric disorders. But within that, we focus on substance use disorders and psychotic disorders. So things like schizophrenia, schizoaffective disorder. So within the substance use disorders realm, there's actually been a fair bit of research investigating TMS as a treatment for a variety of substance use disorders. The overwhelming majority of that research has been for tobacco use and for alcohol use. But actually, there is a small body of literature investigating TMS as a treatment for opioid use. And given the current opioid epidemic, I think it's a really important area for us to be exploring. So the long story short is there's a lot of work to do. And I hope my lab will be exploring that area soon as well.
Dr. Ward, it sounds like TMS is a really exciting option for treatment in substance use. Are there age limitations, or what do we know about TMS for different age groups?
That's a great question. So in substance use specifically, I think TMS is a really exciting new treatment because it's a non-medication treatment and it allows us to offer a treatment for substance use that is non-addictive, that doesn't have a risk of dependence or overuse, misuse. And so I think it's a really exciting option that needs a lot of research to study more before we implement it. But I'm excited to be a part of that research. And as far as ages, so we talked about TMS is FDA cleared for the treatment of depression, OCD, and for smoking cessation. And for depression, what's most exciting is actually just last year, 2024, TMS was FDA approved for treatment of depression in adolescents. So individuals as young as the age of 15. And so that opens up a lot of other treatment options for adolescents who are struggling with depression.
That's so exciting. As you're working with clients, both in your clinic and in your research lab, what are you hearing from them in regards to this treatment? Are they looking forward to their next visit the next day, or after 6 weeks? What do you hear back from your clients?
People really like the treatment, and I think they like it for a variety of reasons. They like that it's a non-medication option. So TMS is FDA cleared for the treatment of depression, and in adults, it's for treatment refractory depression. So in order to have insurance cover the cost of TMS, people generally need to have not responded to multiple medications and to an evidence-based psychotherapy. But we know that in the treatment of treatment refractory depression, TMS is highly effective. Really, 50 to 60% of people experience response or remission to TMS. And that's really impressive given this is a population who has not responded to medications or psychotherapy. And there's even evidence that if you were to use TMS as a first-line treatment, that up to 90% of people would respond to TMS. So TMS is highly effective. It's very well tolerated. The most common side effect from TMS is headache. The literature suggests maybe 40% of people would get a headache after TMS. But really in my research, we have under 5% of people have
Oh,
it.
wow.
And so really that's the most common side effect, but people are willing to come in for TMS every day for 6 weeks for depression because it's safe and effective and really well tolerated.
It sounds like it is a very effective treatment, and we want to be able to get it into the hands or onto the heads of as many people as we possibly can. Is there any discussion about a mobile TMS unit to improve accessibility?
Yeah, certainly. I think a lot of people are thinking about that. The question is, could you bring TMS to the people who need it the most? So I think that's definitely an area.
Right.
There's a lot of research. Or alternatively, could we develop smaller devices that are more for at-home use? Devices now are pretty large and they're relatively mobile, but are there other brain stimulation technologies that are small devices implanted in a baseball cap or that are just much mobile? There's a lot of research in that area as well.
I love that idea. My next question for you is, what does the future look like, Dr. Ward? It sounds like the possibilities may be endless of what we could do with this. Where do you see TMS in the next 10 years?
Yeah. So I think there's so many areas for optimization in the protocols. So there are a variety of different protocols that are FDA cleared that can be anywhere from a couple minutes to much longer. But a novel development also has been the use of what are called accelerated protocols. So in traditional TMS treatment, people come in daily for 6 weeks. And that's problematic for a number of reasons. One is just having to drive into the clinic every day. Another is, who wants to wait 6 weeks for an antidepressant response? The answer is no one, right? It'd be much better if we could get a response faster. So recently, investigators have been testing accelerated protocols where we do not just one session of TMS in a day, but multiple sessions. And some groups have actually condensed them so much to do 10 sessions of treatment back to back in a day for 5 days straight. And so then you could get a full course of TMS, not in 6 weeks, but actually do it in just 1 week. And so really that's an active area investigation for the field. How do we design this as an intervention that really is feasible and accessible for our patients? And so testing ways to make the intervention more efficient, more effective, that's a lot of what's going on. But then also I think a big area, especially in my own work, is the personalization of TMS. So can we understand the brain circuits that are involved in different psychiatric disorders, first and foremost? And then within a person, can we study essentially what that person needs in terms of their brain circuitry? So I kind of think substance use circuitry is a good example. So I'm going to use that as an example. So within substance use disorders, we can sort of think of them as having a faulty gas pedal and a faulty brake. And so the faulty gas pedal is the medial prefrontal cortex, sort of right up the front in the forehead. And that brain region tends to be hyperactive. It's too active in people with substance use disorders. And that's sort of like the gas pedal being pressed to the floor. So you're going 0 to 60. This is the brain circuitry driving craving and the urge to use a substance. There's also the faulty brake, the faulty or the left dorsolateral prefrontal cortex, again, just sort of frontal cortex up here. And that is likened to the faulty brake, meaning you have this impaired ability to exert executive control over that craving. So you can't inhibit your use. You have this craving, and normally you would tell yourself, no, I can't use right now. There are really bad consequences. I don't want to go back to jail. I don't want to destroy my relationships. I don't want to do all these I don't want to use substances because it has such negative repercussions. But this brain circuitry is hypoactive. It's not as active as it should be. So you could think about understanding those two brain circuits in the same person. And maybe one person says, look, Dr. Ward, I have a lot of craving. I am really struggling. And I could say, okay, we're going to use a TMS intervention that targets this brain region and targets craving because that's what you're struggling with. Someone else could come in and say, gosh, I'm just so impulsive. I see a substance and I just want to use it and I can't stop myself. It's not that I'm walking around craving that I want to use the substance. It's just I see it and I can't stop. Maybe that person needs TMS applied to a different brain circuit, right? To a different region to improve their cognitive control, their ability to stop using. So that's what's so exciting to me is to understand first, can we find the brain circuits that are involved in very specific psychiatric disorders and psychiatric symptoms? And then can we personalize TMS treatments for those disorders?
It's all just amazing. It is truly amazing. And I don't mean to put you on the spot here. We didn't talk about this before, but in your research lab, are there opportunities for people in the Nashville area to participate in a research study?
There are. So in my lab, again, we study psychotic disorders and substance use disorders. And so currently we have a clinical trial ongoing testing a personalized intervention, a personalized TMS intervention specifically for nicotine use. We test it in people with schizophrenia and also people without schizophrenia who just use nicotine. And we're testing essentially if one intervention is more or less effective than another one. But we'll also, in my lab, we're generally studying TMS as interventions for substance use and then also for psychosis and substance use within psychosis. We know that people with schizophrenia have a very high prevalence of substance use. We don't fully understand the brain circuitry that's driving that, and we want to understand those circuits and then use TMS basically to fix them. So that's what we're doing in my lab, and it's a lot of fun.
So if I was interested in participating in a research lab, what would be my in a research study, what would be my next step? Where would I go? What would I do?
Feel free to contact us, our lab, the Ward lab at Vanderbilt. And you can see the studies that we have ongoing, see what we're recruiting for. Yeah, we'd be happy to chat. Yeah, we're always recruiting.
Wonderful. Fantastic. In preparation for this interview, I Googled TMS horror stories, kind of looking for a little journalistic sensationalism. And you know what? I came up empty. And I think I think that's even more exciting than if I had found something. There's just so much promise. I think, the emergence, what you're learning, what you're studying in your lab, what you're seeing with the patients that you're treating currently brings so much promise and so much hope to the field of behavioral health care. Just unlimited potential, it sounds like, with very minimal risk. Is that also what you are? Has that also been your experience?
I think that's true. I think I was worried when you went looking for horror stories. I wondered what we're going to find. And I think it's really evidence that people are really excited about the idea of a non-medication intervention. It's tolerated really well. People find it very effective. So yeah, in addition to being a clinical treatment, we can use it in research to really understand psychiatric disorders better, understand the neuroscience of psychiatric disorders, and then ultimately to use that knowledge to develop more effective, personalized treatments. So I think it's incredibly exciting. It's a great time to be a TMS clinician and researcher in the field. Yeah, I think it's wonderful.
Yeah, you're in a good place. You're in a good place right now, Arja. Thank you so much for your work in this area and for sharing your research with us and for explaining TMS to our audience. Again, I'm Laurie Lebo. I look forward to seeing you again in another episode of Centerstone Conversations, Grounded in Science.